we are here to talk about movement disorders and what to do about them. And I just want to let you know that I think that movement disorders are sort of a natural sequelae from movement. And one of the things we're going to do today is to talk about what happens in our brain when you move really well. And I have been fascinated by this for a very long time. When I was 14, I was coming back from Edinburgh in Scotland from my pre-professional ballet exam. And in those exams, I had to stand in the center in my pointe shoes, and there are these very austere ladies with their buns, and they just went like this to me. No words. And there were two of us being examined. And without the music, the pianist started playing the music, and with no delay, we did what's called an enchaînement with our feet on point. That's retiré, entrechotoir, all these things. And on the way home, I thought to myself, wow, how does my brain do that? I didn't really think about it. I just did it. I passed, by the way, so that was good. So I am lucky in that that is actually what I study now. It comes sort of circuitous route through mathematics and physics, bioengineering, medicine, neurology, primate neurophysiology, and here we are. And one of the ways to study how the brain controls movement is to study what happens in the brain when it goes wrong. So let's start off with an engineering type diagram. What are these networks in this finite structure of the brain that are involved in movement? Well, if I was giving an early talk, I usually ask people to go and pick up their cup of coffee or their cup of tea. But if you want to do something that we would regard as very simple, like walking, you'd get up and you'd start walking. But if you, well, you probably don't remember, but if you saw children under the age of 1 who are trying to learn how to walk, it's anything but simple, isn't it? And actually, they look like somebody with a cerebellar stroke until they land like this. But as we grow older, it's almost like we start to store these subroutines. So what we want to do is, the first thing is that our brain says it wants to do a movement. So basically, the command center, the cortex, says, I want to get up and walk. I want to pick up this cup of coffee. And the movement comes out, goes down through basically through the midbrain, through the brainstem, down through the spinal cord, out through the nerves, and into the muscles in a coordinated fashion so that we can do whatever movement we want with the correct initiation, the correct velocity, the correct direction if we're doing a limb movement, and function, and almost as importantly, without contamination by unwanted movements. So if you think about highly trained athletes, you can imagine the coordination, timing, all the senses that have to go, that are involved in doing these movements. So how does the brain do it? Well, in engineering terms, here's the input, here's the output. What's going on in the middle? Well, there's this very interesting group of deep basal ganglia, which means the deep nuclei of the brain, where we may store these subroutines of movement. So as we're learning movement as children, we may have, basically, we're happy when we've stored a walking program because we can get up and walk. And you know what happens once a toddler can walk? Then, life changes a lot for the parents. But if you are a super athlete, you may want to have a very complicated movement routine stored here. And some of you may know, Rudolf Nureyev used to practice what he was about to go on stage and do over and over and over again backstage, so that by the time he came on stage, he was almost in a delirium or delusion. And what I will posit to you is that highly trained athletes and performers actually don't want this part of their brain involved. They want to just pick this out because they have to do this very quickly. And if any of you are involved in a lot of athletes or some high performance movement, you know that if you think about it, it takes too long and you may make a mistake. E.g. the gymnast, you may come off the beam. If you're anxious, anything that involves our cortex messes it up. What I'll suggest to you is that conversely, movement disorders don't have highly functioning basal ganglia. So a couple of things happen. They either cannot retrieve the well-learned motor routines, without going back to first principles and using everything to recreate the program, or they can do it, but it's contaminated by other routines that fall into the mix. So, when we move, and we move a lot, and we continue to move, there's a very important other aspect of this sensory motor system, which is sensory feedback, as you know. So all our senses, in order to walk towards you, I need to see you, I'm feeling my feet on the ground, I'm not actually using my auditory sense to actually walk, but you'll see in a minute some people who do. And then the other organ we need is this cauliflower-shaped organ in the brain called the cerebellum. And the cerebellum is really interested in accuracy, visuomotor trajectories, as we call it, and timing. We need our whole brain to move. And I'm going to show you a video now of two dancers, and I want you to look at them like movement engineers and try and ask yourself, what are they using in order to do this highly skilled movement so well? And it's also really fun to watch. So here they are. These guys are actually using a lot of different dance routines in this hip-hop.
You won't believe it. I'm rather be lonely than happens with somebody else. Might find the night, the right time for kissing, but nighttime is my time for just reminiscing, regretting instead of beginning with somebody else.
So just throw out, what were they using? Yes. They were listening, so they were really right on time with the music, apart from the fact that the choreography is fabulous. They had to spin, so they had to use vision and they had to remember the scene. So ballet dancers learn to spot. So when you do pirouettes, you can't, if you watched everything going around you, when you turned, you would get dizzy. So they have to use their vision. They're obviously using their sensory feedback, but they practice that movement so much that they can do it. They're basically calling up a subroutine. Now look at this one. This gentleman is also moving a lot. Actually, what he's trying to do is he's trying to stand up. And what you can see is a couple of things going on here. Now remember, he is trying to do a simple motor program of standing up. But all this is happening, his head's twisting, this arm's doing this funny thing, this right leg just keeps flipping behind him. So that's an example of what we call a hyperkinetic movement disorder, where the desired motor program is being contaminated by other routines that are coming into the mix. So the brain cannot filter and focus the desired movement very well. Here's another movement that's a problem, and this gentleman had dystonia, and we'll come back to that. Basically, there's nothing else wrong with him. Here's a lady who's having difficulty actually with movement. So she's trying to do that simple motor program we talked about called walking. And her movements, her feet are very close together. She steps in very small steps. And she has great difficulty if she turns. She has to pivot to turn around because she has to recreate that program from first principles. And as some of you will know, if you have friends or family members with Parkinson's disease, the time that people will get into trouble is when they don't have coincident, what we call congruent sensory information. If they're in the dark, if they're walking on rocky path or a thick carpet, that's when they'll get into trouble because it's really hard to bring back those well-learned routines. So today, as we began to talk about, we're going to talk about sort of breaking down these movement disorders that somewhat seem chaotic and a little hard to understand. But if you have a framework for understanding them, they're not really that difficult. We're going to get into what's called functionally connected brain networks through what we're doing at Stanford with imaging and electrophysiology and what's happening with the neural circuits in these networks. We're going to talk about a therapy which is called deep brain stimulation, and which I'll posit to you as the first generation of brain pacemakers. And then we'll look at future therapies that are going to combine very novel technology, such as optogenetics, engineered stem cells, to do this in a more precise way to treat movement disorders and other neuropsychiatric diseases. So here's a question. Here's a finite structure, the brain, and how does it do all these things? So when we move, we also have to think. We have certain kind of moods going on. We have to communicate. And here's the structure where it's anatomically divided up, in a sense, into visual areas, into movement areas, into eye movement areas. And so how does it do this? How does it do this vast repertoire of thoughts, movements, etc.? So the concept is that we have the capacity in our brain for dynamic, which means they move in and out of each other, and functionally connected brain networks. And we do this, it's like a big road map. So imagine a big highway map, and you've got lots of possibilities of connections. And at one point you use this connection, at another point you use this connection, and they're all working in parallel. And this is how our brain works and does all these things with us. It's through parallel, distributed processing in both a spatial and a temporal fashion. And we're going to talk about that. So we'll take you a little bit more into circuitry, and don't get put off by all these arrows, as my students and residents usually sigh and fall asleep at this point, but you won't. So what we're looking at here is we're looking at some of the circuitry in these deep basal ganglia, in that alphabet soup in the brain. Here's that cortex, here's the command center, and one of the reasons that we can do this, and also the reason that we can use brain pacemakers, is that these circuits are actually anatomically segregated. So even though they work in the very same way through the same structures of the brain, they're in slightly different places. So our movement circuits are slightly different place from our mood circuits, which are slightly different place from our thought or associative circuits. And remember, they don't just all work, we don't move without thinking, and we always have a mood associated to when we're moving. So they're all working together all the time. But luckily for us, they are actually anatomically segregated. And we know that, in fact, the brain does transiently network itself in terms of its electrophysiology. So what I'd like to do when I move is I'd like to kind of have all my neurons working independently so that I can link up my arm and hand movement pathways to lift up a cup. I don't want to kick something at the same time. So I want to be able to link these different circuits together at different times. And how we know now that the brain does that is it synchronizes neural activity. So neural activity, think of a broadband spectrum rather like a radio, and you want one frequency for this, one frequency for that, and you want these things to move in and out depending on what you want to do. So we call this transient synchrony, linking together of neural activity from different brain regions, form these functionally connected networks which allow us to move, to sense, to think, and to perceive the world. And this is just a little colorful diagram that everything that's red, more red, is more connected, and everything that is blue is not very connected. And so the brain, this is from the cortex of the brain, and this is somebody at time 0 is asked to move. And this here is a frequency map. And so in these frequencies that will become quite important when we talk about Parkinson's disease, there is a transient desynchronization, and there is a transient increased synchrony in these frequency ranges. And this is one of the ways that we move. We actually desynchronize something that's called an idling rhythm, and we synchronize what's called a kinetic rhythm. And that's just a point in time that will change, as you see, over time. So what happens if we don't do this very well? Well, now there's evidence in the cortex that, say, in schizophrenia, when you show people the broken down facial features, normal controls will synchronize their cortical networks in these what we call beta frequencies in a nice fashion here. But in schizophrenics, this is not done very well. And this is fairly new data, and it's very, very interesting when we start talking about brain networks and synchrony. Many of you know about epilepsy, fairly simple explanation of when the whole brain gets synchronized. Everything starts firing together. That's not good. And so actually people lose consciousness as a protection. so that this desynchronizes again. There's some evidence in Alzheimer's disease that there is again some impaired alpha, low frequencies, and beta frequency synchronization in the brain. We're trying to make these thoughts. We talked about functionally connected networks, and they're not connecting the way they should. And there's some early evidence that, in fact, this is also seen in autism in a slightly different frequency range. So the idea of synchronized networks is extremely important in everything we do. So what about Parkinson's disease? Well, I'm going to show you that we think that Parkinson's disease is sort of the opposite. It's an example of persistent neural synchrony in neural networks, so that the brain networks that are involved in the movement that we just talked about are basically locked in a rhythm. So imagine if you were listening to the radio and your radio got turned slightly off dial, off the station, and you can't hear anything. Well, think about your brain. If it's locked in this frequency and it wants to reach out and move, or like that lady we saw, it wants to get up and walk, it can't do that very well because it's not being allowed to have that versatility of synchronizing in different frequency ranges. But we still haven't proven, and this is what we're trying to do here, that that is actually the reason why it is hard to move. So I'm going to show you a couple of videos, and believe it or not, this is a person in his early 30s who actually got Parkinson's disease in his late 20s. And about 5 to 10% of people with Parkinson's disease carry a mutation of a gene that we think is causative. And if you get this disease at a young age, you have a 70% likelihood of this being the case. Now, what I want to show you is you saw him doing that quite well with his right hand. He is trying to do the same thing with his left hand. He just can't find that program. It's like we thought. He can't bring that subroutine out of the basal ganglia there. And motor signs in Parkinson's disease include a resting tremor, this slowness of movement. They're very stiff, and it always starts on one side of the body. This is actually very important for us when we're trying to understand how to prevent this disease and why it spreads through the brain. So if you get the disease when you're older, you're less likely to have a causative gene. But now there's very interesting genetic studies coming out to suggest that there are many susceptibility genes, so that even if you get this disease as an older person, you still may have a genetic reason for it. Here's a gentleman who got the disease a little older, and you can see the same thing. On one side of his body, there's a resting tremor. His tremor's contaminating his movement here. Remember, we talked about the basal ganglia and when you get contamination of movement, and so the tremor's driving through what he wants to do. And again, he has a hard time trying to move his hand all the way around. And what you're going to see here is this gentleman is going to try to stand up. And in later stages of this disease, even the simplest motor routine that we talked about that we do as a very young child becomes impossible. And the person can't coordinate the movements that we need to get out of a chair, and he needs two people to help him. Now here's this young person, and we've just asked him to walk, and you can see that he's not walking. It's going to take a long time to get that program going. So even as a young person, he may do what we call freeze. James Parkinson described this disease in 1817 and concentrated on the motor signs of Parkinson's disease that we now know are due to a loss of this dopaminergic pathway in that circuit diagram I showed you. And what happens is that everything starts getting unbalanced in these basal ganglia. And for any of the engineers in the audience, you'll see that there are a lot of recurrent circuits here which set up oscillations. And we start seeing oscillations in this part of the brain, and we start seeing increased synchrony. These networks start getting bound up in this rhythm. So early strategies and strategies for the last 40 or so years have been to use dopamine replacement drugs. And what you can see with this gentleman is he can now move nice and quickly, but you can see what happens is now he's getting all this contamination. So now we have that flip side. He can't do the movement he wants to do without this contamination. Same thing with this gentleman. He's posturing. He's having a hard time actually moving. And over time, the medicine becomes your best friend and your worst enemy. And you start having dyskinesias. So other forms of dopamine cell replacement strategies have been stem cells that are not ready for clinical trials yet, but have been very promising, dopamine tissue transplantation, and uncertain gene therapy trials. And so far, they've been somewhat helpful, but unfortunately, they haven't been shown to help for very many years. But that's something we'll talk about at the end. Now, here's another problem that we talked about when we looked at the whole brain. Parkinson's disease is not just a disease of the motor system and those dopamine pathways. And the Brock and Brock group of neuropathologists showed us that, in fact, the pathological feature of Parkinson's disease starts in the brain stem, travels up through the midbrain, and then involves the whole of the brain. And unfortunately, we are only treating with dopamine replacement the part that involves the dopamine circuits. So what can we do about this? Well, we need to start studying the networks. We need to start studying these abnormal networks, and we can do them in two ways. We can do them with imaging in a spatial sense, which my colleague Kathleen Poston is doing with PET studies and with functional MRI scan, and showing that the different regions of the brain are abnormally hyper-connected or not well enough connected. And we can also do this in a structural fashion by using diffusion tractography of MRI with Dr. Scott Atlas here, with my colleague Jamie Henderson. And we can actually look at those circuits from this deep basal ganglia that are connected to other parts of the brain. And what we are doing is we're looking at these pathways, defining them structurally, and then trying to look at them through electrophysiology to determine, in fact, if these parts of the brain are locked in that rhythm. To do this, we have the fortune, when we do the surgery I'm going to tell you about in a moment, to record from these deep structures in the brain that were heretofore we were unable to reach except in primate and rodent studies. And when we insert our microelectrode, we can record from single neurons, and we can record from the population and the network of neurons, and we can see on the single neuronal basis that we've got some abnormal firing that's going on due to that dopamine deficiency and that disease. And in the network, here's this frequency here, and the light and red colors show you that, in fact, the brain, in fact, is locked in this rhythm called the beta band, and also in lower frequencies. Now, I'm just giving you the highlights of this because we don't have a lot of time. So we do this by something called deep brain stimulation, where we use functional stereotactic targeting, and here's Dr. Jamie Henderson, who has pioneered the frameless technique here at Stanford, and then we help him by using our electrophysiology and recording from these deep structures, and we implant brain pacemakers basically in the chest, just like heart pacemakers, and we stimulate these regions, and we basically wipe out that rhythm and restore the brain, we think, to its broadband functioning. And I will tell you that we are now in the first generation of brain pacemakers, and that's where the future lies for us, is in the next generation and subsequent generations of pacemakers, just like there was in the early 60s with cardiac pacemakers. So here's our lady again, having trouble getting up, and she's having trouble, as you know, with the simplest form of movement, which is walking. She's got that very short step gait. You can see the tremor going on, I hope there. You can see her arms are very held stiffly in front of her. And she's going to try and turn around here. And of course, as she turns around, her vision, she has to find that coincident sensory information to turn around, and she's going to come back. And now here she is. She's a year out from her deep brain stimulation operation. She's on no medication. And what you immediately notice is this loose movement, and she can walk without the contamination of any of these unwanted movements. Yeah, that's how we felt. She was actually the first person through our program 12 years ago. And what you can see here is, here's the proof of principle, are we decreasing that locked-in rhythm while we make her better? And here's that we haven't proven this yet, but we have shown in the operating room that here's this beta rhythm, and these black bars show when we deliver deep brain stimulation. We randomized the voltages, and we presented different voltages here, and then over a group of patients, we showed that there was a nice voltage-dependent attenuation of this beta band locked rhythm, and these are the therapeutic voltages that patients have. So first look is, it looks like when we're helping these patients, we're actually attenuating those rhythms. Here's something called tremor. mute this for a second. And here's a gentleman with, quote, benign essential tremor, which you know is anything but benign for people who have this tremor. He can't even try and scratch his head. Here's the tremor recorded on our angular velocity sensors. We apply DBS, goes away, we take it away, comes back, apply it, goes away. So it's nice, it's definitely, we see this in the operating room, it's fabulous. And here he is, with the deep brain stimulators in, my nurse is going to ask him to lift his hands up, and you can see he's completely tremor-free, and I'm sure you have friends who've had this procedure. This was the first indication for it. Here's a little boy, again with this genetic form of dystonia. Now I've broken this movement down for you, so you can tell me, when I tell you he's trying to get up, what's happening in his brain in that alphabet soup. Who's been listening? He's getting contamination with all this extra movement routine. And he can't even stand up. It just breaks your heart to see him. And as I said, with these people with DYT1 dystonia, they really are, everything else is normal. Here he is. He's actually only a few weeks, I should say, out of surgery, because he's still got his scars. His hair hasn't grown back yet. And here he is. He's charging off down the corridor. He was a little shy. He doesn't like us filming him. I don't blame him. And here's our gentleman. This is a gentleman who developed the same form of genetic dystonia when he was about 11. Here he is in his early 20s. And here he is post his surgery. And you can see again, he's not that far out of it. Walking's a little maybe stiff, but he's going to show off in a minute. And he's going to start running down the corridor for you to show you. And he's, if we can't get him back to see us, he's so happy. He's earning money and he's just having a high old time. So I'm just going to end with taking it a little step further. We are now very interested in whether these forms of aberrant or abnormal synchrony in brain networks are actually underlying other diseases. And one of the hot contenders is depression. And as many of you know, we are now looking at deep brain stimulation for depression. And of course, we want to know, okay, if deep brain stimulation helps depression, which Helen Mayberg and colleagues at Emory have shown, is it related to synchrony or aberrant synchrony? And these are just very, very early time frequency spectrograms. And this is the part of the frontal cortex. So we're really thinking of putting these stimulators in areas in fiber tracts that are going straight to the cortex. And you can see that at rest, there's a kind of a lot of blue here. And once the patient's been on high frequency DBS, which was therapeutic, there's increased symptoms. So we've got to understand these neuropsychiatric diseases in different ways. We've got to understand the whole network. We've got to understand them anatomically, electrophysiologically, and we've very much got to know what the abnormal behavior is. Remember, we've got cognitive, limbic, motor circuits, but they're all working the same way. So what we want to do is we want to be able to measure the abnormal behavior, be it what we do in our lab with quantitative kinematics, neuropsychiatric measures, psychophysics. We really want to understand with functional imaging what are the abnormal brain networks spatially, because that's going to give us an idea where we may want to intervene, perhaps, because we have to link these aberrant brain networks with whether there's actually aberrant or too much neural synchrony, because we know now that deep brain stimulation can improve that. And finally, we want to develop what we call nodes for neuromodulation. Are there points in the circuit, and the subthalamic nucleus appears to be one for Parkinson's, that when we interfere with it with deep brain stimulation, it improves the whole functionally connected network? And our friends Theo Palmer and Carl Dijsselroth and our other basic science friends are also doing some very interesting work where they're actually thinking of engineering stem cells, making them behave badly, and using a new technique called optogenetics that many of you may have heard about, where you actually infect a cell and then using light, you can basically do DBS. You can make the cell go faster, you can make it shut down. So now you have a non-invasive way of actually manipulating these networks. So we've gone from first generation pacemakers. We're hoping these are going to get more sophisticated, where we feed off brain networks, just like cardiac pacemakers did in the 60s. We're going to move on to looking at stimulation of the cortex, and then we're going to get further and we're going to actually start engineering stem cells using optogenetics and trying to implant those in these nodes in the brain. So the future looks really exciting for neuropsychiatric diseases, we think, using these types of devices. And at Stanford, this is our large group who are all working together to unravel the mystery of this brain. And I'll stop there. I'm going to, wherever the microphone people land up on.
Have you studied restless leg syndrome at all?
No. We have not, the question is, have you studied restless leg syndrome at all? In this type of work, no, because in the human, you need to be doing a procedure like deep brain stimulation, which has not been shown to improve restless legs yet, or you need an animal model. It is a dopaminergic type of problem, but we don't know exactly what's going on electrophysiologically. But it will come, it will come. We need this to move forward so it's not quite so technologically challenging.
I was just wondering.
Can you just wait for the microphone so
sure.
everyone can hear you?
Thanks. Sorry. I was just wondering that it seems like the DBS kind of overwhelms the abnormal synchrony and just overwhelms it with one frequency, say, or many. And, well, I was wondering if there's any side effects then on other functions. Here one with
very good question.
Overwhelming signal.
Yes. So the question was, it looks like DBS overwhelms the whole signal. And are there some side effects for doing that? So actually, the graph, the voltage-dependent attenuation I showed you, was actually when we looked at that beta rhythm where you saw the big bump, and we normalized it to the rest of the frequency spectrum. So we believe there is more attenuation of that compared to the other rhythms. But you are correct, because in fact, those people who've had DBS sometimes find that their speech can be affected, but speech is already affected in Parkinson's. And we find that if we turn the frequency down, the speech actually gets better. So there's some rodent work that actually suggests that speech may operate at a lower frequency. So there's a little bit of a push-pull there. So that's what we're going to find out as we move forward, is we need these pacemakers to be dynamic, so that if we're sitting down and talking, it flips into another frequency. If we get up and walk, it goes to the walking frequency. It needs to move around these networks so that it picks up where it needs to fire. That's the sophistication we need. And we'll get there. We're just in that first generation right now. Yes, it's a great question.
And just to follow on that, the way, just to think about it, so to say, you use radios and computers as analogies, but can you think of it as like an old-time circuit an engineer would design with capacitors and resistors and frequencies and such old-time things?
We do all the time.
You do? You
yes,
use that
we do.
as kind
We're
of
all
modeling?
engineering nerds in the lab.
Oh, okay. Thank you.
Yeah, we are.
Thank you.
Doing any work with obsessive compulsive disorder, which involves a lot of subroutines, repetitive behavior?
Yes. Actually, we are not, our psychiatry colleagues here are, and there are several centers that have published trials of deep brain stimulation in OCD, and it looks very, very hopeful. We're having a huge problem with the FDA, and we're having a huge problem trying to get money to move forward with this. It's really interesting. Anything there's something that's really new, you get a lot of pushback. So we had a very exciting, it's called Dynamical Neuroscience meeting in November at the Society for Neuroscience, where everybody who's doing DBS for neuropsychiatric diseases was there. And this was some of the discussion, is that moving this field forward, depression has really been shown to be helped by some really good scientists, and they're having a hard time taking it to the next step. So we are very, very hopeful that DBS will be useful for OCD. But as I say, I don't have any of the patients myself, but our psychiatry colleagues do. Yeah. Have you got a loud voice?
Have you done any work with multiple sclerosis where there is a disconnect in the frequency?
So I was just talking to my residents about this morning in the hospital. Multiple sclerosis has a different, what we call pathology. So the nerves are sort of stripped of their insulation so they don't work as well. So how is that involving networks? One would imagine the networks are dissociated. Just on a clinical basis, people with multiple sclerosis have this very serious action tremor. And you saw the gentleman who has that type of tremor, and that is very well treated with deep brain stimulation. And we have done that for tremor in MS. The problem is, for those patients, they often also have that cerebellum isn't working very well, and I told you that was concerned with visual-motor trajectories. So they have something we call dysmetria, which means they can't find the cup because they miss it. And I think one of the hardest things for somebody with MS is that we say to them, we can fix your tremor, but we can't fix this. So actually, we're not going to help you very much. And the downside of the surgery for those patients is that it might actually exacerbate their multiple sclerosis with the stress of the surgery. So it's been used and it's been tried. We've all done it. And nowadays, we don't usually do it because the benefits do not outweigh the risks.
Can you tell me where Michael Fox is at this point with his Parkinson's, and where do you hope to get some more funding from to move on at Stanford?
So I am not Michael J. Fox's neurologist. And I'm not sure I want to do brain stimulation if he did have it, just because I always feel that if there's too much hype, something goes wrong. But that's just me. But Michael J. Fox had a thalamotomy a long time ago, before many of us knew he had Parkinson's. And that was to help his tremor. So that was the very first surgery that used to be done for dystonia and tremor a long time ago, with actually good success. But this was the previous era of surgery where there wasn't as much sophistication nor understanding of these networks. So he has, for whatever reason, decided not to have more surgery, and he uses medication. And he does very well. And the Michael J. Fox Foundation is funding one of our imaging studies, and we would love to see some more funding from them. They are very much focused on what they believe is the need of the year. So they actually have things that they feel are pressing needs, and they focus a lot of their money on that. So one of the things they think is very important to look at in Parkinson's are these other network aspects that I told you about, because I think we all agree that medication and deep brain stimulation can fix the tremor, the rigidity, the slowness of movement. We don't know how to fix the cognitive problems, some of those gait problems. So they're very involved in research in those, and also in research in genetic aspects. So they are very, very interested in the work I told you about at the end, that we wrote a fairly large program project grant to look at, which is the idea of manipulating stem cells and using optogenetics and basically doing subcellular DBS. And that's what we as a group really are looking forward to. It's not quite ready for even primate work yet. But Theo Palmer, Carl Dijsselhoff, Krishna Shenoy, we're all working on that.
I've had DBS operation, and I wondered, can you now fix my speech and my walking at the same time?
Yeah.
And also, what medication does Michael J. Fox use for his?
I don't know. The question is, so do you want to tell them how long you've had it, Britt? You want to stand up? So, would you like to tell everybody your name, or shall I? So, Britt has had DBS for 10 years now, here, and has done very well. Fabulous artist. So what she's asking us is now she wants us to fix her voice, which is soft, and her walking and balance problems, which are non-dopaminergic. And that's our challenge, and that's what we're working on.
Does DBS have an effect on the depression which accompanies Parkinsonism?
That is a fabulous question. The depression in Parkinson's disease is multifactorial, as you probably know, and it actually can be one of the first signs of the disease long before the tremor or the stiffness or the slowness of movement come out. And so it often goes unrecognized that it's Parkinson's. Some people feel that the medicine does improve it, and actually once you've done DBS, you have to be very, very careful, because what we do is we usually switch people over to stimulation and they move down on the medicine. But if you do that too quickly, there are some circuits that are using the dopamine that are mood circuits, And they actually can still produce dopamine, but of course, if they're seeing it from the outside, they won't. So you have to move people down slowly because you can develop a reactive depression from too little medicine. Apart from that, we're really, really interested, like the other depression circuits, whether we can now understand what circuits are involved in Parkinson's disease in depression and in cognition. And I showed you that picture where they're all segregated in the basal ganglia. Well, we haven't studied them enough. That's what we need to do now. And Kathleen Poston here is really interested in that, looking at fMRI, and she's really beginning to differentiate out the circuits that first for cognition and then depression. So hopefully we will be able to do something about it.
I have another question that's not directly related to the topic. Is there any evidence that the majority of Parkinsonism is post-encephalitic?
It's thought nowadays not to be post-encephalitic,
But
mostly.
what's the proof of that? How can you prove that it isn't?
Well,
I'm sorry to interrupt you.
kind
How
of
can you
infection.
prove that it is post-encephalitic, first of all? How do you prove
I
it?
think you can't, who knows except for pathology and autopsy, but I think it's the association with the old form of post-encephalitic Parkinsonism with the epidemiology, with the fact that there was this epidemic, and then there was this post-encephalitic Parkinsonism, which was different from the type of Parkinson's we see today. I think another question you could ask is, how do you know that all Parkinson's disease isn't in some form genetic? And that's the challenge we have to ask too. And so, as many of you know, there's 23andMe, which Sergey Brin helped start this big registry where they're really encouraging everybody who has Parkinson's disease and their families, especially families with family members, to sign up so that they can really try and understand how many genes are susceptible, causative, or just non-contributory. So I think we have those very large-scale challenges ahead of us.
Question would be, have you used this also for chronic pain management?
Yeah.
And has it been...
Yes, Dr. Henderson has been very interested in DBS and motor cortex stimulation for pain. And in fact, he was talking about it at this meeting. And there are some successes, but overall, there hasn't been a huge improvement. And I've been in the operating room with him trying to map out parts of the brain with this, which is obviously different because it's not a motor circuit. And it's been very challenging. And so is that because we haven't found the right spot? Is that because pain is more distributed? We don't know. But the biggest problem is that insurance companies stopped paying for it. So it became something that was much harder for people. Even now, Dr. Henderson has actually done recently a DBS in a different nucleus as a compassionate care for somebody. And we all met as a group in the hospital to decide how this should be done. And the patient, just by talking to him, is apparently doing quite well. So he thinks that there is some avenue for this. Yeah. Can we have a mic down here? Oh, I've got the big zero. Oh, is that the zero or is that your hand? Oh.
This notion of synchrony, turning on or off other pathways, there are two natural phenomena that might be interesting. One is touch typing, where if one thinks about what finger is going to do the key, it slows down and breaks up the task. And the other, meditation.
Yeah.
Have those been productive at all?
So I developed a keyboard, which I started off using a musical keyboard, and that's exactly the movement I used, was this alternating finger tapping task. And I can tell you that people with Parkinson's disease did better when they have vision or auditory feedback or both. So they need that coincident, congruent sensory feedback. People who are on their medicines or who are on healthy controls do slightly better when they have no sensory feedback. So it's again getting to this idea that if you're a healthy control with a normal sensory motor system, you want to take that cortex out of the picture. But if you have Parkinson's disease, you need to recreate the movement. And we've actually used that task to show that. That's actually that's been shown to correlate with all the motor assessments of Parkinson's disease. Intel took it on and developed an engineered keyboard along with another couple of movement devices, and we started this several years ago with digital health technology, and we were at DC in 2005 showing this off, and we did a small study just basically with proof of concept is could people with early stage Parkinson's actually do this combination of little motor tests once a week at home, and we fed it into a computer. Actually what came out, we found they could, and what came out is that the keyboard was actually the most sensitive to pick up motor progression in early stage PD. So we're seeing that the coordinated task, even though it's that well-learned trill, is actually very sensitive to Parkinson's disease. So what we're doing now is we've engineered another keyboard, which Dr. Poston can use in at the fMRI scanner, and which I use in the operating room, and we're combining all these studies so that we use it in the operating room while we're measuring these LFPs, and we've just started that. So that's something that we're hoping to understand. Intervention, does it help movement? Is it causative? Great question. You want to come work in my lab? No.
I haven't heard you relate to anything your science is doing with Alzheimer's.
Well, that's partly because he hasn't heard about my talking about anything that my science relates to Alzheimer's, and that's partly because my own research is in movement disorders and not in Alzheimer's. Dr. Longo and his colleagues are working in Alzheimer's, so different members of the department. But I can tell you that we're all working together. So Dr. Poston is actually, and Dr. Kirchner are also doing combined studies in fMRI. I'm doing the kinematics for some of their patients with dementia. So we're bringing all of this together. So yes, we are, but personally I'm not running that. So I hope you went to see Dr. Longo's talk at 10 o'clock. I think I've got the zero sign being flashed up there, so I think I'm happy to talk to anybody in person down here afterwards. Thank you very much.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.